So welcome all to this webinar series. Today, I have the honor to have Professor Peter Wormald and Dr. Alkis. First of all, I want to thank you for your time and to share with us these amazing lectures. Some years ago, a couple of years ago, I met you in Adelaide. It was one of the most amazing experience. And I'm really thank you very much for sharing with us all this time. I know you are very busy. And so today it's going to start, PJ, you're going to start?
Alkis is going to start.
Alkis is going to start, sorry. Alkis is going to start. And I hope you all enjoy this webinar. And please, first of all, before we start, I beg you that if you have any questions, you can write in the chat and we will answer all of them, or at least we'll try to answer this question at the end of the webinar. So let's begin and enjoy.
Great.
Now I'll stop share my screen. There we are.
So I'll share my screen now. So thank you, Lourdes, for inviting myself and Professor Wormald to present. I'm going to present on the maxillary sinus. Just checking before I start that you can all see my presentation.
Yes,
yep, great.
We see perfect your presentation.
Fantastic. Okay, so if it doesn't run or you can't hear me or you'd like me to slow down, please let me know. So I've been asked to speak to you about maxillary sinus surgery and the structured approach that we employ in this department in order to ensure that we're doing the right extent of surgery for the right amount of disease and that we're using the right approach for the right disease. As a background, I'm going to touch on the following areas, the reason why we have a structured approach and how it interacts with the inflammatory disease that we see in the sinuses. I'm going to classify disease and propose a new classification system for how we can stage the type of disease that we have. And finally, give the surgeons and the clinicians in the audience a ladder of how to approach them so that when you see the preoperative CT scans, you can plan your surgery before you actually go to the operating room. So obviously, endoscopic sinus surgery became functional endoscopic sinus surgery when Messinkliger and Stamberger popularized addressing the natural ostium. Prior to their reinvigoration or re-knowledge of how the sinuses drain, we were just putting holes anywhere in the sinuses, whether they be in the inferior meatus or through the anterior face of the sinus. But these patients, despite clearing the disease, had high rates of recurrence, and hence the reason to address the natural sinus. And here we can see a diagram taken from the initial book, and we can see that the osteomeatal unit is really very important to understand in terms of the drainage of the sinus. That osteomeatal unit sits behind the first and second lamella of the sinus, the uncinate process, and the bulla ethmoidalis. And here we can see the hiatus where the sinus will drain into. Here is a picture from many years ago where we can see the surgeon has performed an inferior antrostomy through the sinus. You probably can't make out the disease in the maxillary sinus labeled MS, but there's still ongoing disease despite that ostium being open. And that's due to the fact that the natural ostium wasn't addressed and there's perpetuation of inflammation and poor drainage of that sinus. So now when we do surgery, we really want to make sure we get the natural os. Now the natural os isn't typically visible with a 0-degree scope in an unoperated case. So here, what we're seeing is an accessory os. And the inexperienced surgeon may simply enlarge this accessory os, believing that they are addressing the natural os. The problem is that if you don't address the natural os and you simply enlarge in the accessory os, there will still be ongoing inflammation of that sinus and possible mucus recirculation. And here is a picture of mucus recirculation. And here we can see its real-time movement of the cilia. And we can see that the cilia are not draining through that posterior accessory os. What they're doing is they're beating towards the natural os, which is obstructed. And as a consequence, there's no flow of mucus outside of that sinus. So let's look at the osteology, and it's really important to understand the bony landmarks, because if you can understand them, then you can get a better understanding of the surgical approach. Here we can see the middle turbinate. In this particular case, it's pneumatized. So this patient has a left pneumatized concha bullosa. And then we can see the thin bone coming off that middle turbinate onto the lateral nasal wall. And this is the uncinate process, which in many cases is actually perforated. We don't see those perforations when we're operating because the bone is mucosalized. But a lot of the uncinate processes are perforated. And that's why when sometimes you do an uncinectomy, you don't feel the bone crunching away the whole way along. Now, that uncinate process inserts into the lateral nasal wall. And if you look at the thin bone just anterior to that uncinate process, this is the lacrimal bone, showing the close relationship between the lacrimal bone and the uncinate bone. And obviously, if care is not taken, you can injure that bone and the lacrimal duct underneath. Now, it's really important to know that that lacrimal bone doesn't go the whole way up. It doesn't extend the whole way up of the uncinate process. At the top of that lacrimal bone, we have the ascending process of the maxilla, or the frontal process of the maxilla. And this is important for two reasons. Firstly, when we perform DCR surgery, we need to remove this bone with a rongeur or a drill in order to expose the entire duct and nasolacrimal sac. But more importantly, when we think about maxillary sinus surgery, it shows that we are actually above and in front of the orbit if we cut forward with a sickle knife. And so we have little risk of damaging the orbit if we're coming from a posterior to anterior position. Now, traditionally, uncinectomies were performed in an anterograde fashion. So a sickle knife was put up against the lateral nasal wall and it was plunged through the uncinate process. But this shows you how you don't have that same protection if you're doing this procedure, and you're more likely to injure the orbit. So let's look at this patient. This patient has a fairly well pneumatized maxillary sinus. However, the osteomeatal unit is obstructed and there's subsequent disease in the anterior ethmoid cells and the bulla ethmoidalis. This patient has slightly more disease. We now have mucosal thickening of the maxillary sinus, and the pneumatization is less than it was on the previous scan. And finally, we have this patient who, if we look on the left, has double densities, which signifies likely fungal deposition and complete obstruction of that maxillary sinus. So this patient we deem as grade 3 disease with complete opacification of the sinuses. Now, what we advocate is that the same surgery should not be done, or the same extent of surgery should not be done for all 3 patients. The first patient is likely to need a less invasive and less extensive procedure. So let's look at this patient. Here we can see a patient with maxillary sinus disease, and we can see pus sitting within that maxillary sinus. Here we can see a patient who has fungus sitting within that maxillary sinus. Now, if you did the same procedure on these 2 patients, there is no way that you'll get all the fungus out of that second patient. And this is why in these patients, we need to do a more extensive procedure. Again, we have a patient now with a thick eosinophilic mucin, and you can see the thick tenacity or the viscosity of that mucus. These are patients who need more disease, more surgery, because they've got more disease and they've got a higher inflammatory burden. So when we talk about inflammatory burden, we look at the different etiological causes of sinusitis. Now, many different theories have been put forward, and probably the reality is that chronic rhinosinusitis is a combination of all these different theories. Things that can contribute to a high inflammatory load are staphylococcal enterotoxins, biofilms, thick eosinophilic mucus, fungus, polyps, and osteitis. And so these contribute to high levels of inflammation within the sinus. What they generally have in common is that the more eosinophils you see, the more significant the disease. And we know from the literature that the more eosinophils that we have in the blood and the more eosinophils that we find in the tissue at the time of surgery, the worse the disease preoperatively and the higher the grade of inflammation. If we look at postoperatively, there's good evidence to show that inflammation also correlates with worse postoperative outcomes. So let's look at the eosinophil, because this seems to be the driving cell in the sinuses. Now, the eosinophil has multiple functions. It can present antigens, it can elaborate pro-inflammatory cytokines, and importantly, it can attract more and more inflammatory cells. Once that process has begun, we start to see tissue injuring and tissue remodeling. Now, the thing that happens is that once the process begins, it's got autocrine nature, which means that it can perpetuate. So unless you get rid of as many of those eosinophils as possible, this process will continue. And this is why in patients that have complete opacification of their sinuses, if you don't get out the vast majority of that inflammation, the disease will progress and continue to progress, and eventually will become resistant to steroids. Now, should we do the same surgery for all extents of disease? We propose no. We believe that the patient with grade 1 disease should simply undergo an uncinectomy and a slight enlargement of the maxillary antrostomy. Here we can see a swing door approach where we have made the top cut, we've made the inferior cut, and now we're swinging out that vertical portion of the uncinate process. This will allow us to visualize the natural loss, and then we can simply remove the horizontal portion of that uncinate so that we can enlarge the ostium by removing the complete uncinate vertical and horizontal portions. So in this patient with minimal disease, the aim is simply to ventilate the sinus and then to preserve as much mucosa as possible so we can get healing by primary intention. Now, with grade 2 disease, you need to be a little bit more extensive with your uncinectomy. Again, we're performing a swing door uncinectomy. We're removing the vertical portion of the uncinate process, and then we will start to dissect out this horizontal portion. You can see that there's a lot of disease within this sinus, almost to the point that you can't see that natural loss clearly. So what we're doing here is we're extending the antrostomy posteriorly to the posterior maxillary wall by removing all of this inflamed tissue, going through the posterior fontanelle of the maxillary sinus, and we're starting to visualize the inflamed mucosa of this maxillary sinus. And here we can see that there is pus sitting at the bottom of that sinus, and when we use a 70-degree scope, we can see that there's this thick mucus, which we don't want to leave behind. If we leave this mucus behind, essentially we're setting up for more of that autocrine eosinophilic-driven inflammation. And so that's why we do a large antrostomy to visualize the entire sinus and use suction and irrigations to remove that mucus. Also, we know that by increasing the size of the maxillary antrostomy, there's more chance that our topical steroid irrigations will be able to get in and treat the disease. Now, here we have this patient with fungal sinusitis, severe disease. These patients can either have a high inflammatory load due to biofilms, fungus, or eosinophils, or they could have a significant deposition of disease due to the fact that the sinus cannot clear itself. And these are patients with poor mucociliary clearance. These are patients with cystic fibrosis, or patients in the first group who have been left so long that they start to get irreversible modeling of their disease. So a study was performed by Roby in the 2000s to assess the limitations of different endoscopes and different instruments. And essentially what he showed was that with a 30-degree scope, we can only access about 40 to 50% of the sinus. In order to visualize more, we need to use a 70-degree scope and angled instruments. But even in these patients, we can really only access about 70% of the sinus. You can see that the anterior inferior disease in this particular sinus can't be seen or addressed easily. So for this grade 3 disease, if you leave this 30% of residual disease behind, what's going to happen is that you're leaving behind these inflammatory cells. And as a consequence, it will perpetuate more disease. And here you can see why a patient has got ongoing disease despite open antrostomies. So for these patients, there are really two options to treat them and evacuate the disease. The first is the canine fossa trephinum, and the second is the extended maxillary antrostomy or modified medial maxillectomy. Now, with the canine fossa trephinum, there's an instrument set that you need. Here we can see the instruments, the introducer, the drill, and the guard. And when the description was first described by Professor Wormald, we essentially relied upon anatomical landmarks. Generally, it was thought that if you use the line or the point that is intersected by the mid-pupillary line and the nasal seal or the nasal floor, and you make your entry point here, you're more than likely going to miss the infraorbital nerve as it exits through the infraorbital foramen. And so it reduces the risk of neurological injury. Here we can see an axial cadaveric section of the axis that this approach provides. And with a straight shaver, we can see that we can access almost the entire aspect of that sinus through that antral window. In summary, how do we do it? Well, you make an incision, and it's a small incision. This is an old video where the incision was slightly bigger. We raise a small amount of soft tissue. And as I said, now when we do this procedure, we raise less soft tissue than we've showed in this video. Once we've raised the soft tissue with the suction freer, we check the landmarks, the mid-pupillary line and the nasal seal. We put the guide of the instrument in and we drill with irrigation so as not to burn the bone. And it's very important not to burn the bone as it can cause osteitis. Now we have a 30-degree scope, but you can use a 70-degree scope in the nose and the shaver in the maxillary sinus. And here you can see removal of all of that inflammatory disease, those polyps that are lining the sinus. Now, it's really important when you do this that you remove as much of this disease as possible, but you don't strip the mucosa, as was described in the initial caudal luck procedure. We don't strip the mucosa because if you do, you're setting up yourself for ongoing inflammation, crusting, and discomfort for the patient. But you do spend a considerable amount of time, and you need to be patient, getting as much of that inflammatory disease as possible. And here you can see that the surgeon has really addressed the vast majority of that disease. Once you finish the procedure, you simply pull the shaver out or the debrider out, and you leave the incision to close by itself. It doesn't need a stitch because the nasal mucosa or the oral mucosa is very moist, and it's a small incision which will close up by itself within a few days. And here is a picture back in the sinus 6 months down the track, and you can see that the sinus is widely open and that it's disease-free. So obviously, whenever we do surgery, we want to back it with evidence. Gone are the days where we simply advocated doing a procedure and didn't have the evidence behind it. So if we look at the canine fossa trephinum, and Professor Wormald, who described this technique, has done a lot of research into the outcomes of this procedure. And Kristen Sieberling, who was a fellow in this department some over 10 years ago, looked at the patient's disease-free survival and found that 80% of them had no disease quite a long way down the track. They also looked, the same group, at the benefit in patients with Samter's triad. And again, in these very diseased patients who historically do very poorly with surgery, they have a much better long-term outcomes than patients who simply have large antrostomies. The recurrence rates at 6 and 12 months were less than 4%, which is a really significant improvement in these patients with horrible disease. So now, obviously the procedure is effective, but what are the risk of side effects? And so again, this was studied in 2005 initially, simply on the surgeries that were used using those two anatomical landmarks. And unfortunately, what it showed was that almost 3 out of 4 patients, 76%, had very high complication rates. The vast majority of those complications were minor complications. It was soft tissue swelling due to the incision, and probably because we raised a little bit too much of the bone off the front face of the maxilla. But there were a percentage of patients who had facial numbness. And this was obviously due to damage to the branches of the infraorbital nerve as it branches over the anterior face of the maxilla. The good news is that the vast majority of complications seemed to improve by 1 month, but there was still 1 in 10 patients who had persistent symptoms at 6 months. And so a complication rate of 10% is not really acceptable for a non-malignant condition. And so let's see why this was the case. Well, the reason is if we can see on this cadaver that using the landmarks that I described previously, you're going to miss the main trunk of the infraorbital nerve in the vast majority of cases. This obviously is the most common way that the nerve branches once it reaches the face. But there's a group of patients where you have multiple distal branches that come off a lot earlier, and they branch over the front face of the maxilla. And obviously, these terminal branches are vulnerable to injury if we use those same landmarks and rely entirely on them. And so for this reason, the technique was modified. It was improved. And it was modified that not simply relying on these landmarks, but to look at the front face of the maxilla once you've raised the soft tissue up. And so here you can see that this patient has a nerve branch with the arrow showing it, branching over the front face of the maxilla. Now, this is exactly where those 2 landmarks corresponded previously. But in this particular case, the surgeon has identified this, and they've changed their approach by going slightly lower and more medial. And in doing so, the patient hasn't experienced the neurological problem. Now, obviously, we need to be very careful not to go too low, because if you go too low, you'll get into the teeth roots. And if you do this, you've got risk of damaging the tooth and alveolar region and causing tooth loss. So you really need to be thinking at all times when you modify those landmarks. So the second study was done where we looked at this endoscopically modified technique and found that the complication rate dropped from 75% down to 45%. And most importantly, the long-term complication rate dropped down to 3%. Now, we think the reason that we had such a high long-term complication rate, still of 3%, was because we were raising too much soft tissue off that front face, and so possibly damaging little nerve branches. So nowadays, when we do this technique, we make a very small incision in the buccal gingival sulcus and raise a very small amount of soft tissue just to give us enough of a chance to visualize the bone and then to enter without having too much bone exposed. So that's the first approach. And I suppose the disadvantage of the first approach is really twofold. Number one, you need the equipment, and I don't think the company makes that equipment anymore. And number two, after you've done the surgery, you can eradicate all the disease, but you still can't visualize post-operatively the entire sinus. So you still, even with a 70-degree scope, you can't visualize that anterior-inferior area, and you'd need a flexible scope. And so in terms of surveillance of disease, it's less perfect than it would be if you could visualize the whole sinus. So this then brings the extended maxillary approach. And I've used a patient without too much disease here to show you essentially what we're removing. We're removing the uncinate process, the vertical and the horizontal portion, and making a large antrostomy. And then what we're doing is removing that medial maxillary sinus wall. And so we're getting access to the entire sinus. We are preserving most of the head of the inferior turbinate because we don't want to create empty nose syndrome or significant drying out of that nasal region. This is a cadaveric section, and we're looking at the left nostril here. And here we can see that we've extended the antrostomy posteriorly from that natural os, and we've extended it inferiorly through the midsection of that inferior turbinate, preserving the vascular bundle posteriorly and the head of the inferior turbinate anteriorly. I really want to take a bit of time to look at that vascular bundle. Here we can see the size of that inferior turbinate artery and also the nerve that runs with it. So when you're doing this procedure, it's really important not to go too far back. And if you do, you must cauterize this area very carefully. Otherwise, the patients can get a significant post-operative bleed. Now, the advantage of this procedure is that if you extend it anteriorly, so this is the modified medial maxillectomy component of it, you can come right up to that piriform aperture. So here you can see we can access and visualize the entire sinus. And with a 30-degree scope or a 70-degree scope, you get the same visualization as you do on this sagittal section. And it's really important because you can get rid of all the disease and, importantly, monitor these patients post-operatively. And this shows you how we do it in real time. So here we can say the patients had previous surgery, they've got a scarred natural os, they've had a partially resected uncinate process. So what we do, first of all, in all of these approaches is find the natural os, because this will be a guide to where to make our incisions. We then clamp the head of the inferior turbinate, and this is done for hemostasis. And we really try to preserve as much of the head of the inferior turbinate as possible. We then remove the middle third, and I like to create lateral nasal wall flaps, which are based medially and inferiorly. And the reason I do this is to limit the amount of bone exposure after you perform this procedure. You then use a freer to simply break through this soft bone, and you place this anterior osteotomy at the level of the natural os, because you know that you will be posterior to the nasolacrimal duct. And this bone is typically very thin, that it can be easily removed with a blade sleeve. So here you can see we're now in the inferior aspect of that sinus, and we're removing this thick, tenacious mucus, which would not have been able to be removed via conventional maxillary antrostomy. Using a heavy backbiter, not a pediatric backbiter, we can then extend this antrostomy anteriorly below Hasner's valve. And so we won't damage the nasolacrimal duct. Now, Hasner's valve almost invariably or always exits at the axilla of the inferior turbinate. So provided you stay below that, you've got a very high chance of missing it altogether. And here we can see that even though we've had done that big antrostomy, we couldn't access that anterior disease without doing the modification anteriorly. And I want to draw your attention to the fact that you could see that anterior wall with a 30-degree scope. And here we are now cauterizing the turbinate. Now, when I first did the procedure, I only would ever raise an inferior flap to cover the inferior bone. But now, as I think the biggest problem with this procedure is the amount of crusting that you get post-operatively, I remove the posterior bone and then I rotate mucosa laterally over the bone so that there's no bone exposure at the end. Now, I've seen this procedure done with chisels and drills, and I would really recommend that unless the bone is super thick, that you don't use these instruments, and I'll tell you why. The descending palatine nerve runs in the inner canal just posterior to this bone of the medial maxillary wall. And if you chisel or you drill, you increase the risk of an inadvertent injury to that descending or greater palatine nerve. As a consequence, the patient will experience palatal numbness, which will be permanent and possibly disabling. If you use simply a freer, you create a large enough antrostomy, and only the bone that is thin will fracture. And as a consequence, you limit the chance of damaging that neurovascular bundle posteriorly. And so here we're looking at the patient post-operatively, and we can see that we've got a large antrostomy and there's no disease post-operatively. So again, this has been studied in terms of long-term outcomes, and this was initially studied by the Stanford group in 2008. And they looked at 28 patients who had had these extended modified medial maxillectomies and showed that all patients had an improvement and that the 75% had a complete resolution of symptoms, very similar to the ones that we saw with the canine fossa trephine. Now, another group in South Carolina also did an independent study, and they had very similar success rates with a slightly longer follow-up. When I was at Stanford as a fellow, we looked at the long-term outcomes in the initial cohort of patients and showed that at 7 years, they still had the same success that they had at 12 months. No patients got worse, all patients improved, and almost 3/4 of patients had complete resolution of their symptoms. And these are just graphical representations of that cohort of patients, which shows you the stability of their symptoms and the stability of their post-operative endoscopic scores. Recently, we published a study where we wanted to assess whether the extent of maxillary sinus surgery we performed correlated to the amount of the sinus that we could access, as well as the irrigation penetration post-operatively. And this study essentially used cadavers. And what we did first of all is we performed 5 different extents of surgery. In the first surgery, we simply removed the vertical portion of the uncinate process. In the second surgery, we removed the vertical and the horizontal portion of the uncinate process, and we didn't enlarge the antrostomy. In the third extent, we enlarged the antrostomy posterior, but not inferiorly. In the fourth extent of procedure, we lowered the antrostomy down to the nasal floor. And in the fifth, we extended it anteriorly to the piriform aperture. And what we found was that when we looked at the amount of irrigation post-operatively, by opening the antrostomy inferiorly and also anteriorly, as you would with a modified medial maxillectomy or an extended maxillary antrostomy, you increased the penetration from 65% up to about 80%. And so for these patients who have significant severe inflammatory disease, you can now treat that disease post-operatively with pulmicort irrigations. So let's look at those 2 techniques very quickly, and we can see that the canine fossa is probably a quicker technique, although once you become comfortable with an extended modified medial maxillectomy, the procedure is very quick as well, and it only takes about 5 minutes. Removing the disease takes a longer part. This has got less post-operative crusting, the canine fossa, because you're not exposing bone within the maxillary sinus. Whereas with the extended maxillary antrostomy, you don't have to have a special kit. You've got better visualization post-operatively and possible less long-term complications in terms of neurological injury. But both are really good techniques. So in the final few minutes, I just want to speak to you about the pre-lacrimal approach. So the pre-lacrimal approach is really important for laterally based maxillary sinus disease or anteriorly based maxillary sinus disease. And it's important because these areas are traditionally very difficult to access through a standard maxillary antrostomy or even a modified maxillary antrostomy. We weren't the first people to describe the pre-lacrimal approach. It was first described by Bing Zhu in China, but we have made our own modifications and published our technique in the International Forum of Allergy and Rhinology in 2015. And it also provides these diagrams, which can help the surgeon who wants to perform this procedure do it. In simple, we make an incision at the head of the inferior turbinate, extending it right down to the floor of the nose. We then raise the mucosa off the turbinate bone. And here you can see the arrow highlights the piriform aperture. We then make osteotomies through that anterior part of the turbinate. In this initial description, we actually incorporated the piriform aperture into those osteotomies, but now we don't because we think we get less post-operative notching and nasal deformation as a consequence. Once we've made these osteotomies, we flick the bone off to expose the underlying mucosa of the maxillary sinus. And then the bone, which sits behind the nasolacrimal duct, will easily fracture away because the nasolacrimal duct is a natural dehiscent through the bone, and the bone is very weak on either side. We then remove the mucosa of the maxillary sinus to enter through that pre-lacrimal window. And if you've got a very large tumor, you can completely transpose the nasolacrimal duct and work on both sides. And then simply it requires one stitch. So the advantage of this procedure is that you don't disturb the inferior turbinate long-term at all. And so there are no issues with drying out of the nasal mucosa or the sensation of an empty nose. So this is a procedure for an anteriorly based inverting papilloma. This patient had had 2 prior procedures prior to seeing me, and essentially had recurrences every 12 months. And the reason is that through that standard antrostomy, which you can see here, they've really left that attachment site unaddressed. This is the preoperative view of that anterior disease. And just like we showed you in the pictures, here you can see, in this particular case, we're using infiltration. You don't have to use infiltration. And then we're making an incision hard up against the thick bone of the ascending process. We extend it right down to the floor below the inferior turbinate, so that we can raise the mucosa off the lateral nasal wall and off the inferior turbinate. Now here you can see that we've exposed the piriform aperture. This was an early video. We don't do this anymore to expose that anterior edge. And in this particular case, we're creating our osteotomies, incorporating the piriform aperture. So this is more like a modified Denker's procedure in terms of the tissue removal. Now we simply only remove that lateral wall, leaving the piriform aperture intact. Now this bone easily fractures off that nasolacrimal duct and it can be pulled out. And here you can see the anterior window that we have. In this particular case, we can see that we've got that disease sitting in that anterolateral aspect. We can improve our access by drilling down a bit of the front face of that maxilla. And here we're using a 30-degree scope to visualize the entire anterior wall. We can now strip the mucosa off the bone because we know that that's very important in addressing the attachment. And once we've done this, we can then address the bony spicules and the rest cells, which are creating ongoing disease. And so once we've removed the attachment, we can start to drill this bone away and minimize the chance of recurrence. Now, the attachment typically bleeds because it has significant inflammatory reaction. And this is what we're going to be addressing now, is this bony attachment. And using a drill, we are now drilling down that attachment, which is the reason why this person has recurred so much. Here you can see we're drilling it down and we're now cauterizing the attachment for hemostasis, but also to minimize the chance of recurrence. And then simply, we reconstitute the inferior turbinate with a simple stitch. This patient is now 4 years post-op with no evidence of recurrence. So very, very briefly, I just want to speak to you about mucus retention cysts. They're incidental in up to 40% of patients. They're usually asymptomatic. They're non-infectious. And generally, we advocate observing them. We don't advocate removing them because they really are asymptomatic and very common. Odontogenic sinusitis should always be suspected in a patient with unilateral maxillary disease. They can have dental causes or they can be related to implants. Typically, these patients present with facial pain. They have postnasal discharge, often very purulent. They can smell the infected sinus and mucosa. And it's really important that dental pain is not always present. And so often the patients will be sent to the dentist and the dentist says, the teeth are fine. It's not the teeth, it's the sinus. But if you look at this study, only 30% of patients with odontogenic sinusitis actually have pain. So pains are not a good predictor. So what are good predictors? Well, if the patient's had any recent dental work, if they've got a foul-smelling discharge and they have unilateral disease, you have to have a very high suspicion of odontogenic sinusitis. And they typically present with pus in that region. It's missed in about 50 to 86% of patients who have OPGs because OPGs, similar to plain films for sinuses, do not always detect sinus disease. CT scans are more predictive, and what we see is the sinus is completely opacified. We have unilateral disease. We can often see a periapical abscess like the one that you've seen here. We get bone thinning and bone remodeling, and often it gives you the impression of a foreign body reaction. You can get double densities due to the mixed anaerobes and the fungal colonization that also occurs in patients with odontogenic sinusitis. The microbiology is always positive when you take a culture. They've got a really high burden of disease, and usually it's not one bacteria. It's the polymicrobial nature of the oral flora. So many bacteria are present. But the good thing is that these are very sensitive to antibiotics when you treat them. So how is it different to chronic rhinosinusitis? We usually have a lot more bacteria, and usually you have anaerobes and aerobes mixed in together. Generally, augmentin will work in the vast majority. That's amoxicillin and clavulanic acid, but doxycycline is a good antibiotic as well. And obviously, there are second-line agents if the patients are sensitive or they're resistant to the first line. So how do we treat odontogenic sinusitis? Well, there's no consensus. People think that surgery is advocated, but there's disagreement as to whether or not you should remove the tooth first, or treat the dental cause, or treat the sinus. The reality is you probably need to do most in the vast majority of patients. These are the different studies. One study suggested that you shouldn't just do the sinus, you should address the tooth, because if you don't do the dental surgery, they will relapse because the initial source of infection is still there. The studies where they showed doing the sinus surgery first, about 33% seemed to do well, but 60% actually required further procedures because they had infected teeth causing ongoing disease. So generally, to avoid these patients failing, I would advocate addressing the infection, which is the tooth, and draining the sinus to get the bacteria out of the sinus. What are the predictive factors of the patients needing surgery? Well, if the whole sinus is involved, they're going to need an operation. If the osteomeatal unit is blocked, the sinus isn't draining, and so you need to open that up in order for the sinus to drain after the tooth is removed. If you see foreign bodies or fungus or a large cyst that's blocking the sinus, you then need to do a complete removal of the disease and an opening of the sinus. And so this is a patient with odontogenic sinusitis. If we look at her scans, she didn't have a lot of disease within the sinus, but the osteomeatal unit was blocked. And here we can see where the tooth had been removed, there was an ongoing inflammation. About 6 months later, she started getting a complete opacification of the sinus. This is a more anterior view, anterior to where that tooth had been extracted. And we can see that she has got significant ongoing disease. And this is her video. Here we can see we're entering the tissues very inflamed. The dentist actually called me because he thought that she had a tumor, given the amount of sort of changes to the bony anatomy of that sinus. We perform a septoplasty. I do a septoplasty in almost all patients because the tissue is so inflamed that if you don't remove the deviation, you're going to get adhesions between the surgical site and the septum. So I have a low threshold to doing a septoplasty in a patient with a narrow nasal cavity that's inflamed. Here we can see it's still very narrow. So to maximize our access, we're going to remove the lower part of the inferior turbinate. This doesn't cause any functional problems, but what it does allow you to do is to get better access so that you get less chance of adhesions, but it also allows you to monitor this patient post-operatively. Here we can see that even as we enter that sinus, we're having pus pouring out of that maxillary sinus. And you can see how much ongoing inflammation there is. And this was a patient that had that affected tooth removed, but still had ongoing disease 6 months down the track. So once we remove the uncinate process, we can then address the maxillary sinus. And here we're removing the uncinate process, and I'll just speed it up. And now we're entering into the sinus, and this patient needs a big antrostomy because they've now got secondary fungal infection. And you need to get all of this fungal material out in order for the patient to do better. And here you can see we're removing the fungus. we're creating a big antrostomy. And I decided in this case to do a modified medial maxillectomy because I was very worried about what was going on antero-inferiorly. And I was very worried about the irrigations penetrating this area post-operatively. And so this patient has done very well. Now, I'm not going to go through the next ones because we really are probably started a bit late. But I really want to leave you with three points. First of all, think about your maxillary sinus surgery. Don't do the same procedure for different disease. If a patient has cystic fibrosis or fungus in their sinus, I would say in these patients, go straight to the modified medial maxillectomy. These patients will fail a standard antrostomy, and you'll be back there in 6 months' time treating their disease. And finally, for patients who have a high burden of disease, I do try to do a standard antrostomy, a large antrostomy initially to give them the chance of not requiring a modified medial maxillectomy. And so these patients are the ones that I would consider of doing the modified medial maxillectomy as a second procedure. But I must admit that I'm becoming more and more aggressive in my treatment of maxillary sinus disease in order to ensure that the patient doesn't require a second operation. Thank you.
Thank you very much, Alkis, for this great lecture. Now we continue with the lecture of Professor Wormald. If you want to share your screen, and at the end of the lecture, we will read the questions from YouTube. And if any want to make any question here also in this chat, you are free to do, and we will read all the questions that the time allows us. So thank you very much again to both of you, and let's begin with your talk.
Thank you, Lourdes. You hear me okay?
Yes, we are seeing perfect.
Okay, good. So I'm going to talk to you today about optimizing the nasal airway. Those are some disclaimers, not any of them are relevant to my talk. The aims of my talk today is to discuss something which I think is very common to most surgeons, in the fact that everybody should be able to do the primary surgeries that are involved in optimizing the nasal airway. So all ENTs should be able to do septoplasty, inferior middle turbinate reduction, and even sinus surgery. So I think that, understanding the physiology behind nasal airflow is a critical part of making good decisions as to what should be done and what shouldn't be done. And we're going to look at the different features and anatomy that create nasal obstruction in the nose. I'm going to actually look at septoplasty techniques, because I really do think that septoplasty is not a well-taught operation, and that there are easy and they're difficult septoplasties. And so we'll go through some of the techniques. We're also going to discuss in some detail how we manage the inferior turbinate, because I think, again, there are lots of different operations that you can do on the inferior turbinate, but some of those are not as good as others. And I'm going to go through the reasons why I think that's the case, and also look at the anatomy associated with that as well. And then finally, we're going to look at middle turbinate techniques and just briefly discuss how you assess a patient's nasal airway and how you decide what operations are appropriate for each patient, dependent upon what you find when you do the assessment. So if we look at nasal obstruction, it's a very common presenting symptom for ENT surgeons. And we'll see that when we look in the nose, we've got a blocked nose, and it consequently causes a lot of problems for the patient's partners at night, which can even lead to unsightly solutions by frustrated partners during the night. And the next morning, both the patient and the patient's partner do feel a bit worse for wear. At the moment, how do we know how to assess what actually occurs in nasal airflow? So what we can see here is a diagram anteriorly in the nose before. This is the area of the nasal valve, where the pink and red colors illustrate a very fast nasal airflow, and the blue colors illustrate a much slower nasal airflow. And see, as we start to go back to the head of the inferior turbinate, we can see how that internal nasal valve is a very narrow area with a very high nasal airflow. If we go further back and we start to now see the middle turbinate coming to view here, we start to see where does the nasal airflow go inside the nasal cavity. And when you ask this question to a lot of surgeons will tell you that the majority of the nasal airflow goes through the inferior meatus, so it goes down here. Whereas that's not the case, as we can see from these diagrams. The majority of the nasal airflow doesn't go through the inferior meatus. It goes around the middle turbinate towards the middle meatus. So if you look at this video, which is an actual patient's video, we can visualize the nasal airflow and see how the nasal airflow moves through that nasal cavity. So this is the patient's left side. This is the patient's right side. And we can see what happens here. Internal nasal valve, head of the middle turbinate, inferior meatus. How much of the airflow is actually going through the inferior meatus and how much of the airflow is actually going towards the middle turbinate. So it's really an interesting phenomenon that the dynamics and physiology of nasal airflow is poorly understood by a lot of the surgeons who do that. So this is looking anteriorly at that same patient, and you can see what happens here in terms of the nasal airflow. You can see how you get little eddies which go up to the olfactory area to give you the ability to smell. We can see what actually happens here in terms of turbulence within the nasal cavity and visualize that quite nicely. The other is another patient. These are actual patients where we've done the nasal airflow on actual patients. In this patient, quite a lot more air going through the inferior meatus. So here we are having some air going up towards the middle turbinate, but we've got a much greater proportion of that air going through the inferior meatus. So if we look at it from the top, this is a top view. So looking at from the nasal cavity, looking at what happens to that airflow through that nasal stream. So if we look at what actually happens, there are two areas in our nasal cavity which we really need to pay attention to. The one area is the internal nasal valve. And the airstream comes in through the internal nasal valve and doesn't actually hit the anterior end of the inferior turbinate. It actually hits the top of the inferior turbinate, the shoulder of the inferior turbinate, the head of the inferior turbinate, but the superior surface of the head of the inferior turbinate, and then heads up towards the middle meatus, and then is often divided by the middle turbinate. So it's pushed down through that middle meatus either medially or sometimes laterally towards the maxillary sinus where it enters the sinus. Here we can see the airflow coming through from the top view, and we can see most of the air traveling on the medial surface of that middle turbinate as that middle turbinate divides the stream. And another good example again of how that airstream is divided by the head of the middle turbinate, showing you that the middle meatus is absolutely critical in achieving a good outcome for your patient. So not just managing the inferior turbinate, but managing the middle meatus and the middle turbinate is critical in getting a good nasal airflow. So here you can see the airstream is projected up and backwards. It's not projected along the floor parallel to the floor of the nose. The airstream projects upwards and backwards into the nasal cavity. And understanding that really is important when we're making our decisions as to how our patients should be surgically managed. And we're going to go through that in some detail, is really going through the steps of assessment that you need to do to get your nasal airway appropriate. So the things that we need to address or need to look at and assess are the septum, the inferior turbinates, the middle turbinates, and we also need to look at whether there's inflammation of the nasal cavity and sinuses as a consequence of there being chronic sinusitis present at the time, because that'll also influence our choice of surgery that we perform. So here we do important principles in septoplasty. If we're going to do a septum, we need to do the septum properly and correctly. The first and most important thing is identify the correct surgical plane. So if you don't identify the correct surgical plane, your septoplasty is going to be a mess. It's going to be bloody, and it's not going to be in the subperichondrial plane, and you're not going to be able to see the anatomy that's appropriate. It's absolutely critical that you get into the correct surgical plane. The second most important principle with the septoplasty is you must keep one flap intact. If you have a very prominent spur, the mucosa is tented across that spur, and the mucosa becomes very thin where the spur tents that mucosa. And if you take out the spur, there's a high likelihood that you're going to get a tear of that mucosa. That doesn't matter as long as you have one flap intact. So it's critical that you keep one flap intact during your surgery, because you'll often get a tear with that sharp spur. When you do get a spur, don't take out a portion of the bone, because if you leave bone behind, that tear that you've created is tented by that bone that you've left behind. So when you do get a tear, make sure you take out all the bone so that that tear can sit back up against the other flap, which is intact. So we like to suture the tears at the end of the procedure as well to keep the mucosal edges together, and that will give you a good outcome for your septoplasty. There's a video just of a basic septoplasty. Here we can see a very prominent spur here in the middle meatus and another maxillary crest spur. There's an anterior deviation here. Here, this anterior deviation we can see, and middle meatus looks okay. So first we will infiltrate, and then we will make our incision. And you can see I make my incision really anteriorly at the mucocutaneous junction, because you can't come anterior once you've made your incision. You can go posterior, but you can't come anterior. The fracture lines, these are fracture lines in the cartilage, often cause some adherence. There's also adherence at the bony cartilaginous junction, and we can see that here. We're going down onto the floor of the nose. Now we go across onto the opposite side. We know that we need to keep one flap intact. So we've preserved 90% of the cartilage. We've now got the bone. We're on the opposite side. We're going to go down all the way down to the floor of the nose. So we're going to keep dissecting this. This is that anterior deviated cartilage. We're taking that out. This is the spur. We've dissected above and below the spur. We now fracture the spur away from where the spur is, and then remove it. And we can see we've got clearance of the spur, and we've got clearance of our deviated cartilage. We then do a plication suture at the end of the procedure to hold our incisions in place, and then tie that onto the skin. You've got to tie that final stitch on the skin, and then you have your nasal cavity. What about inferior turbinate techniques? Well, there are lots of different techniques: total inferior turbinate, partial diathermy, submucous diathermy, coblation, turbinoplasty. So total inferior turbinectomy used to be popular, but really associated with significant hemorrhage post-operatively, a lot of crusting, atrophic rhinitis because of all the removal of all the tissue in the nose, empty nose syndrome because all the airflow receptors that are associated with those turbinates are removed. But in some patients, it did give you good symptom relief. It does have a much higher tendency to have a patient that ends up with empty nose syndrome, and that's because there's no airflow receptors. When you have your turbinates in your nose, your turbinates provides resistance to the airflow. When you take those turbinates out completely, you lose the resistance to the airflow. And sometimes that loss of airflow receptors and that ability of the patient to be able to pick up that airflow over those mucosal turbinates, then the patient perceives nasal obstruction and empty nose syndrome does occur. So we want to maintain the torpedo shape of the turbinate at all times, because the torpedo shape of the turbinate preserves the mucosa, but also preserves that resistance and the sensation of nasal airflow. So partial inferior turbinectomy, again, used to be popular. I don't think a good operation because of removal of too much tissue. Submucous and surface diathermy, you damage the ciliary, you damage the mucosal surface. There's a lot of associated necrosis and hemorrhage associated with it as well. Coblation, again, a lot of tissue removal, a lot of damage of the medial wall of the mucosa, and expensive because you need the tissue. Turbinoplasty is what we recommend and what we're going to show you. We will remove the bone, we preserve the functional mucosa, we preserve the airflow receptors, we preserve the torpedo shape of the turbinate, have minimal incidence of hemorrhage post-operatively, and minimal crusting as well. It does take more time, however, to do this, but we have really good outcomes and we've got good data to suggest that. So to understand the anatomy of the inferior turbinate, here we look at the osteology. And here we can see that the inferior turbinate bone forms a significant proportion of the obstruction that that turbinate creates to nasal airflow. What we can also see is that there are lots of these little bony projections and these little canals that we can see which harbor the blood vessels that run in that inferior turbinate. And if we look at the blood vessels, generally speaking, there are 3 blood vessels that occur in the inferior turbinate. This vessel here, which is the major one, is the medial superior vessel. And then we have 2 vessels that run along the inferior edge of the turbinate, one which is lateral and one which is medial. Most of the time, we have 3 vessels. We did a cadaver dissection in 16 cadavers. We did 50 patients to identify this anatomy of this vasculature to see what we could see. So 60% of the patients had 3 arteries, 30% had 2, and 10% had 4 or more. So of these arteries, this one is the most common we found. 96% of our patients and cadavers had this artery present, the one that runs medial and superior. 82% had this one that runs lateral and inferior, and 70% had the 3rd vessel, which runs medial and inferior. So really, to understand those vessels, the anatomy, how they run in these bony canals is really important. The other important factor is that the most common blood supply to the inferior turbinate doesn't come from the sphenopalatine branch of the postnasal artery. It actually comes from the descending palatine artery. So in our cadaver study, 70% of our cadavers had a major contributing branch from the descending palatine artery. And that's a common misunderstanding, that we think it's a branch from the posterior nasal artery. So what does it look like when we do an inferior turbinate plasty dissection? So here we can see that we are creating a little window anteriorly. We're identifying the bone. And like a septoplasty, we're making sure that we get onto the bone with our dissection. You must get onto the bone. You must be in that subperichondrial plane with your dissection. Here you can see the vessel here, the superior medial vessel being dissected out of the canal. We can see the canal here, and the vessel that now being dissected out of the canal. This is the inferior lateral vessel here. We can visualize that as we dissect that out. I'll just go back to where we were. And then as we get back towards the posterior aspect, here we can see these vessels have a lot of anastomosis between each other. So this is that superior medial vessel with a lot of anastomosis connecting it. This is the medial lateral vessel. And we actually go and cauterize those vessels where they exit from that greater descending palatine artery. And we can see the medial vessel now on the floor, superior vessel here, and they've all been cauterized. We then roll that turbinate laterally, and we can see that rolling that turbinate laterally gives us that torpedo shape, but then gives us that beautifully patent nasal cavity as well. What about the middle turbinate? Well, concha bullosa, retrocurved middle turbinate, excessively bulky middle turbinate, excessively long in terms of how it comes down towards the floor of the nose, can all be prominent. So here we can see a concha bullosa. And for a concha bullosa, I like to actually make my incision as to what I want the turbinate to look like. So I actually cut the middle turbinate where I want that turbinate to end up and how I want that turbinate to look. So I make that initial incision to actually stylize that turbinate so that I get what I want to get out of that turbinate at the end of the procedure. So how do we assess a patient for what they need to have when they have nasal airway optimization? Well, we do an endoscopy. Here we can see significant deviated nasal septum, a large inferior turbinate, concha bullosa on the other side. So we can visualize that. But we also need to look at the CT scan. If you look at this coronal plane, we can see here you've got the deviated nasal septum. You can see the big concha bullosa coming up. You can see there's no associated sinus disease. And if we look at the inferior turbinates, we can see that there's prominence of those inferior turbinates with very large inferior turbinates. So we are able to, both on the endoscopy and the CT scan, evaluate our patients significantly. We need to identify each of those factors that contribute and which of those factors are going to be addressed. In this patient, the septum, the inferior turbinates, the concha bullosa, if the patient has CRS, we need to decide, is it a significant disease load? And its impact on the decisions that we need to make are going to make above. So if we look at this, if we start with an easy patient, we look in here, you can see it's a minimally deviated septum here with a little spur. There are big concha bullosa bilaterally. If we look at the inferior turbinate, look how prominent the bone is in the inferior turbinate. And so this patient, straightforward, needs the septum done, inferior turbinates done, and the concha bullosa addressed. So we can see that inferior turbinates already are very prominent on this patient with very thick bone. Concha bullosa we can visualize as it comes up here. That definitely needs to be part of our addressment. There's no significant CRS with this patient. So what we'll do is the septum, the concha, and the inferior turbinates. There's another patient. Here we can look very significantly deviated septum, but look at all the sinus disease that this patient has. So if we have a lot of sinus disease, deviated septum, you can see the deviated septum is quite significant. What about the inferior turbinates and the middle turbinates? Do we have to address the middle turbinates? Well, there is a little bit of a concha bullosa here on the right-hand side. So in this patient, what will we do? So in this patient, we'll do the septum, we'll do the chronic sinusitis, and will we do the middle turbinates? Yes, we'll do the right middle turbinate, but not the left. Will we do the inferior turbinates? Even though this patient's most prominent symptom is nasal obstruction, we will not do the inferior turbinates in this patient. Why will we not do the inferior turbinates? Because there's a significant disease load in the sinuses. And once we've done the sinus surgery, the inflammation that causes those inferior turbinates to enlarge will be addressed. And you do not need to do the inferior turbinates when you've got a patient who's got a lot of this sinus disease. You only need to do that in patients who don't have significant sinus disease. So here we have a patient. If we have a look at the septum, deviated septum, maxillary sinus disease, but no other sinus disease, but very large turbinates. So in this patient, we had a lot of sinus disease. In this patient, we didn't. We had, all we need to do is a mini fez where we address the maxillary sinus. We need to do the septum, and we'll do the inferior turbinates because the amount of disease load in this patient is not enough to give you significant swelling of the inferior turbinates. So what we really need to do is each patient's assessment needs to be individualized. If you have a lot of disease, don't do the inferior turbinates. If you have minimal disease, then you do need to do the inferior turbinates. If you have concha bullosa, then you need to deal with the concha bullosa and deal with the middle turbinates and the middle meatus as well. So the other comment I wanted to make was about septoplasty. How do you identify septoplasties that are easy and septoplasties that are difficult and septoplasties that are very difficult? Because not all septoplasties are the same. This is an easy septoplasty, straightforward, no problems, standard spur, very easy to do. This is a very difficult septoplasty. This is the most difficult septoplasty you can have because this deviation of the maxillary crest, where you get the maxillary crest folded over to one side, is very anterior. and very difficult to get a surgical plane underneath that crest, and very sharp spur. And so the likelihood in this patient is that you're going to end up with a tear all the way along this maxillary crest spur. So if we look at this patient, we can see here, this is that maxillary crest spur that we can see here. We infiltrate that. We make our incision. Initially, we get our septal plane. We will then go down to the actual spur itself. And we can see here, we're on top of that spur, but very difficult to get anteriorly underneath it. We need to have one flap intact. So here we're going to come and we're going to take this incision anteriorly here. So we go above the spur. We want to make sure that we have one flap intact. We're going on the opposite side. We're going to go all the way down to the floor of the nose. And once we've got that one side intact here, we can see making sure we're going onto that. When you have a very tight adhesion here, don't push with your freers. Don't push it. Use a sharp scalpel blade where you really have got a very sharp adhesion. But you can see here, we really need to get this off so that we can get this flap intact. So we don't want that to tear. So we're making sure we get onto the bone with the scalpel blade, get down onto the floor of the nose. So we're keeping that flap intact. Now we've got the flap intact, we can take out the bit of cartilage that forms that spur, but it's not the cartilage that's the problem. It's the bone that's the problem. So we can take the cartilage out and that'll come out okay. The good thing is I can take you back to where we were. So we can take the cartilage out okay. So the cartilage will come out. Then we're left with a bony spur, and it's the bony spur which is the problem. Not so much here, but anteriorly. You can see how the spur comes right across anteriorly, and it's in that internal nasal valve where you have this spur that's folded right across. So getting this anterior base spur out is really critical to getting a good result for this patient's septoplasty. So once you're able to do that, you can also, if you need to, use a osteotome to be able to do that, be able to get this spur out. We can see we've got a little tear there along that crest, but the septum itself is very good. Now this is that patient, the same patient that I showed you, the CT, that had a lot of sinus disease. So you can see the turbinates, we've addressed the septum. The middle turbinates, we're not going to address. Concha bullosa on this side, we will address. So we'll do the concha bullosa on one side, and we will, again, we're going to cut that concha bullosa exactly where we want it. So we cut it so that the concha bullosa ends up looking exactly how we want that turbinate to look at the end of the procedure. So once you've cut it, fold it down, and then take a straight through biter and just cut the posterior attachment off. And then once you've cleaned it up, there's always a blood vessel here at the back that you need to address, bipolar, and we have our concha dealt with. We don't need to do anything with the turbinates. We clean out the sinuses on both sides, leave the inferior turbinates alone. So we've done the concha on the one side and septum, and we haven't done anything to the inferior turbinates. And then we do the plication suture to the septum to finish it off. So, you know, concha bullosa, inferior turbinates. Here we have a patient, again, we'll have the same problem here, a different patient with that very similar problem, concha bullosa, but no sinus disease in this patient. So again, if you're looking at it, again, you've got this big septal spur and crest that we need to deal with. And we do the septum much the same way. We'll come down, and this is taking out that anteriorly based fold over crest. And I think this is the most difficult septoplasty that you can do. Really important that once you've taken it out, this is the mucosa of the tear, deal with that concha bullosa, no sinus disease. So in this patient, we'll need to do the inferior turbinates as well. So we'll go on and we'll expose those inferior turbinates, just show you that dissecting out those inferior turbinates will give you the view of those vasculature. So here we can see the vessels as we describe them. We will cauterize them and roll that inferior turbinate over. So we've got a good nasal airway. why do we need to preserve it? Well, you can see what happens to the temperature of the air as it passes along the inferior turbinate. It's really important that we maintain that mucosa for both humidification and for cilia work. What happens when you've done your septoplasty and your septum is now straight, but you've got a very narrow nose? There's nothing that the patient's had an inferior turbinoplasty done previously, but this portion, this internal nasal valve is good. What happens when your cartilage collapse is minimal? So there's Cottl's maneuver is negative. So you can't say that this is caused by prolapse of the lower lateral cartilages. What do we do in this patient? We need to move this lateral nasal wall laterally. How much space do we need to create? You'd be surprised at how important 2 millimeters of space can be in terms of improving that nasal airway. So, if you can get more, good, but 2 millimeters is probably all you need to do. But in this patient, there's 2 ways to do it. One is once you've done your inferior turbinoplasty, and we've finished our inferior turbinoplasty, here you can see us dissecting out of the blood vessels. We've cauterized the blood vessels at the posterior end, exposed them. Here we can see the blood vessels coming through and out of the descending palatine artery. We now want to take away the little bit of a head of this inferior turbinate.
That. Could you try again?
Sorry, that's Siri decided that she was going to listen to what I'm saying on my phone here. So once we've opened up the and cauterized the vessels at the back of the inferior turbinate, we want to come anteriorly and deal with the head of the inferior turbinate. So we'll come up here and you'll see this is the head of the inferior turbinate. We want to move this further laterally because you've still got a very prominent shoulder here of that inferior turbinate. So you can take an osteotome and just expose that mucosa a little bit, and just taking an osteotome, just do a little osteotomy on that head of that inferior turbinate, just taking that bone out. And that's one way to improve this very anterior head of that inferior turbinate. The other one is this particular patient, which I showed you the initial picture for. What we did with this patient is we want to do a pre-lacrimal approach. So Alki's shown you that already. So we're going to come with a pre-lacrimal approach. We're going to make our incision, expose the bone, take the bone out from that head of that inferior turbinate. Once we've cleared the bone, we now got that very prominent anterior aspect of the head of the inferior turbinate. Using that osteotome, we're going to move that piriform aperture laterally. We're going to take out that piriform aperture and remove it laterally by taking that bone, exposing the nasolacrimal duct. We can see the nasolacrimal duct here, clearing away the bone behind the nasolacrimal duct, and then the whole inferior turbinate we're going to move laterally to improve that, that nasal valve area. So just taking the last of that bone away, you can see here, and then we can put our flap back up. And you can see how, when we looked at that initially, how this piriform aperture was really narrow, and we can see the space we now have from that piriform aperture once we've taken away that bone. So look at the difference now compared to what it was when we started. And giving the patient that extra 2 to 3 millimeters of space is really what we need to improve that nasal airway. So really understand the nasal flow, understand the physiology of the nose, understand the anatomy in terms of how the blood vessels look on the different turbinates, and what role the turbinate bone actually plays, how you can, by identifying the vessels and cauterizing them, we don't need to pack the nose afterwards. We don't put any packing to prevent bleeding. We don't need to worry. We just leave that all completely alone afterwards. Standard surgical techniques for septoplasty really understand the importance of getting the surgical plane, of preserving one mucosal flap, but also understand the importance of concha reduction and dealing with the middle meatus, because 60% of the nasal airflow goes through the middle meatus. And if you're not dealing with the middle meatus, you're not dealing with 60% of the nasal airflow. Understand your techniques for inferior turbinoplasty, make sure you understand how to assess the patient. Use both your endoscopy and your CT scan to assess all the different components on the scan, because that's critical to deciding the outcome. Don't be doing inferior turbinate surgery in a patient that has chronic sinus disease, because you take away the inflammatory processes with the chronic sinusitis. You don't need to have done the turbinates, because the nasal airway will improve. So ex-fellow of mine, Claudio Callejas from Santiago in Chile, has translated this textbook, and Claudio was a fantastic fellow and runs an excellent course now in Santiago. And so if you want to purchase the book in Chile, you go to Amolca, and in Argentina, the fellow who's doing the book is Nestor Pardo, and that's his phone number. So happy to take any questions, should anyone want to fire them up.
Thank you very much, and PJ. The lecture was amazing, and for sure, many people will buy that book, because here in Argentina we use your book in all our universities. First of all, thank you very much for all. Sorry about the technical procedures and the technical complications we have. There was like the electricity ran off in the university. So that was the reason why they couldn't make us work the link. So I want to, first of all, thank very much to Dr. Fanny Rodriguez, who allows us to use her webinar, his Zoom link. So that's the reason why we could solve this problem. And well, sorry for the inconvenience. I will share some questions that they have just asked here in the Zoom and also in the YouTube. We have a couple of questions first for Alkis. They say, let me check just 1 minute, because I have to translate. They have done the questions in Spanish. How do you treat odontogenic sinusitis, and what technique do you use to close the oroantral fistula?
So I've got a very good dentist, an oromaxillofacial surgeon that I work with. So generally I do the sinus and they close the fistula. The technique that he uses is he likes to use a buccal fat rotational graft, and then he undermines the mucosa. He puts the buccal fat into that location and then he stitches it up. But I just do the sinus aspect, and I do a large antrostomy. Unless there's fungal depositions within the sinus, I won't do a modified medial maxillectomy, because I feel like once that sinus drains and you've removed the infected tooth, the sinus will stabilize.
Okay, perfect. This is for both of you, or both of you can answer. They ask if you prefer Denker endoscopic or pre-lacrimal access to those tumors that have anterior implantation.
Yeah, so I would much prefer a pre-lacrimal approach. You know, Denker's is essentially just an extended pre-lacrimal approach. I think if you can preserve the nasolacrimal duct and you can preserve most part of the inferior turbinate and therefore the nasal physiology, you have a better outcome. You know, medial maxillectomy, which is what the old-fashioned Denkers would have been. So it would have been a medial maxillectomy with drilling of the anterior edge of that piriform aperture away to give you the same access. I think is really a little old-fashioned in terms of sinus surgery, and we would only do that if we felt that the pre-lacrimal approach would not give us sufficient access, or there was some other reason why we thought that the pre-lacrimal approach wouldn't work. I can't think of one now, just off the top of my head, but we would definitely, our first choice would be pre-lacrimal rather than the old-fashioned medial maxillectomy and Denkers.
Okay, perfect.
Well, I would advocate the same. And my main reasons for not doing a Denkers is the fact that you get notching of the alar, and cosmetically, patients aren't happy. Once you've treated the disease, that's when they start to look at things a bit differently, and that's when they get fairly unhappy. And so I think with the pre-lacrimal approach, which I didn't mention and I should have mentioned, is that there's some people whose anatomy does not predispose them to having a pre-lacrimal approach. So you have to assess the scans in the axial plane preoperatively, and you want to make sure they have a pre-lacrimal recess or pneumatization of the bone anterior to the lacrimal duct. Generally, they need about 4 to 5 millimeters of pneumatization in that region in order for you to be able to get an endoscope or a shaver into that region. Because if you don't look at the scans, and this has happened to me when we were doing an early case, and you think that every patient can have a pre-lacrimal, you actually get into the nasolacrimal duct. There's no window to get access. So have a look at the scans preoperatively.
Perfect. And this is for PJ. They ask if you have any patient with empty nose and when you resect the middle turbinate.
So thank you for the question. So touch wood, I've never had a patient who I've operated on ever, for whatever reason, end up with empty nose syndrome. I've never had a patient with empty nose syndrome. So, you know, the techniques of preservation of the inferior turbinate mucosa, I think, are critical to not ending up with empty nose syndrome. We've certainly, middle turbinates are much more forgiving. So I don't think that the middle turbinates have a great role in nasal airflow perception. I think the shoulder, the upper surface of the head of the inferior turbinate is really where a lot of the sensory elements are for nasal airflow perception by the patient. And so, you know, complete resection of the inferior turbinate is much more likely to give you an empty nose syndrome than resection of the middle turbinate. Now, we used to be very conservative with the middle turbinate, and I'm no longer conservative with the middle turbinate. I feel that if a patient has bad polyposis or significant disease load, like for instance, all my patients who will undergo frontal drill out procedure, all of them, I will trim the lower half of the middle turbinate away in those patients, because I really want to be able to deliver topical medication to those patients to prevent disease recurrence. And I think one of the problems with the middle turbinate is that if you leave it, it can swell and it can cause obstruction of the ethmoid sphenoid complex as well as the frontal sinus, and you don't get good penetration of your topical medication. So I think the middle turbinate is more forgiving to being resected than the inferior turbinate. So I'm not as conservative with the middle turbinate as I am with the inferior turbinate.
Okay, perfect. And it says, do you have any treatment for, this is for both of you, if you have any preference technique for the treatment of caudal septum deviation?
You want to answer, Alki?
Yeah. So if it's a caudal deviation, I really think, first of all, you need to be doing a hemitransfixion incision. If you do a completely endoscopic incision, you won't access that caudal strut. And so the patient will fail in my hands. So I think you have to decide, can you do a septal reconstruction, or does the patient need a complete external septal rhinoplasty? And I must admit that I think in terms of long-term results, these patients do much better if they're referred to a facial plastic ENT surgeon who can reconstruct that whole septum, because you can address it and you can get it straight at the beginning of the procedure, and you can put a stitch and drill a hole through the spine. But with time, unless you put straight cartilage in, that cartilage will start to get its memory back. And within sort of 3 months, these patients, in my opinion, will start to fail again. So if it's a really caudal deviation, and you need to assess, is the caudal deviation due to a fracture of that anterior 1 to 1.5 centimeter, or is it because of a posterior deviation that's clicking the septum forward? If it's due to the former, the anterior deviation, external septal rhinoplasty. If it's due to a posterior deviation that's causing the septum to overgrow and click forward, you can try doing a septoplasty, but you have to advise the patient that there is a chance that they will fail that procedure.
Okay.
Yeah, I must say I agree with Alki. I would patients who've got and caudal dislocation of your septum can be in various degrees. So you can get fairly minor caudal dislocation. You can get just the very 2 millimeters, anterior 2 millimeters, which is curved, or you've got to assess the whole thing. But when you've got the whole anterior cartilage bent in a continuous bend that's dislocated, those patients are best treated by an external septal rhinoplasty, complete removal of the cartilaginous septum, and probably swinging it back to front. So putting the back end of the cartilage in the front and the front end at the back to reconstruct that septum, and then putting struts in that you need to support that repositioning of that cartilage. And like Alki, I don't do rhinoplasty work, and so I'd send it to someone, an ENT, who had a rhinoplasty interest as well.
Okay, perfect. Here in Argentina, it's very common that rhinologists do both of this surgery. They use plastic surgery. That's the reason why I think that they ask. Another quick question is for you, Peter. With the small concha bullosas, if you also resect it or if you just crunch it, like
so
if
I never crunch anything because
but I that in English is like if you.
I understand what you mean. You crush it. You're crushing the turbinate rather than resecting it. Yeah, I understand what you mean. So I never crush because when you crush something, you're leaving all the bone behind, and you're leaving that crushed bone in place, and you're making an ideal area for new bone formation, a chronic infection, and you're really not getting a significant change in your anatomy from that crush that you create. So I don't like crushing at all. So if I have something which I think is obstructive in my assessment, I'll do a resection of it. I won't crush it. And I don't like crushing. And it's the same with, it's one of the reasons why I don't like balloon sinuplasty, is that, I think that when you dilating a nasal frontal sinus ostium and you're crushing the cells out the way and you're leaving all the bits of crushed bone behind, you don't get as good a result as if you do endoscopic procedure and resect it.
And also a last quick question: if you out fracture the inferior turbinates, because they say that you didn't mention that on the lecture.
Yeah, so I don't think out fracture of the inferior turbinate on its own is a procedure that I would do. So you would have noticed that once you resect the bone of the inferior turbinate, there isn't any bone left, any vertical portion of the bone left. So you are actually moving the residual mucosa laterally, but it's not supported by any bone. So you're not actually fracturing anything. So I think just fracturing the inferior turbinate without removal of the bone of the inferior turbinate doesn't achieve much, and it's not something that I do.
Oh, okay, perfect. And this is a question for both of you. If you use Rhino Devito manometry to evaluate the functional of the obstruction of the nasal obstruction.
Okay.
Yeah, so I have used rhinomanometry in the past. I think if you have a patient where you're not 100% sure that they are psychiatrically sound, that I would do rhinomanometry before. And the reason for that is that I think that empty nose syndrome, in my opinion, is probably due to an underlying, it's controversial, but an underlying psychiatric predisposition. So for patients that I'm a little bit unsure that their symptoms actually correlate to what I'm seeing endoscopically, I will do it because these are the patients who will be unhappy. And we've all had these patients where they've got a very blocked nose, you do surgery and they still feel blocked afterwards, but their rhinomanometry has shown a significant improvement. And in those patients, you have objective evidence that you've improved them. Likewise, in a patient who says, I feel blocked, but they don't have a lot of disease to start with, you can quantitate that they've got normal rhinomanometry before doing anything. And so these are the patients that I wouldn't operate on, because these are the patients where if you even do coblation, they will report nasal obstruction afterwards and possibly could sue you because of empty nose syndrome. So for me, I have to have 3 criteria before I operate on turbinates. First of all, the patient has to give me a very good history of turbinate obstruction. So they have alternating obstruction is very important for me. Secondly, they have to have a very good response to decongestion. So when you decongestion in your rooms, objectively you see an improvement, and subjectively they feel a lot better. If they don't feel any better with decongestion, then they're not going to feel better with surgery. And finally, and this is where I have to have two of these three criteria, I have to have good evidence on rhinomanometry that there is obstruction. So that's when I would do rhinomanometry if it just doesn't make sense to me.
Yes, I think rhinomanometry is a research tool. It's not something that we use in routine evaluation of our patients. So for me, we've used rhinomanometry in some of the papers we've published in terms of an outcome, objective outcome criteria for our patients. But I agree with Alki, be careful of those patients who you have a sixth sense that there's not all going to go well after the surgery, because it's a bit like rhinoplasty. You know, if you can pick those patients before you operate on them and don't operate on them, you can save yourself a world of pain in the post-operative period.
Okay, perfect. I think that we are already in time. I want to thank you very much for all your patience, and to all the panelists that here we were more or less 160 participants, and also in YouTube there was a lot of audience. We will share the link from the YouTube, so if any couldn't make it today, they can also revisit in our channel, and they can also see again this amazing lecture. It would be an honor for me to visit you again in Adelaide when all this pandemic pass over. And if you have the chance to come here to Argentina, you are always, you and Alkis, welcome. You know that here in Argentina, we are big fans of you. So thank you very much again. And sorry to all the audience for the inconvenience. Once again, here in Latin America, sometimes we have these kind of problems. There was a shutdown in the electricity in the university. So we have to change the link. But at the end, I think that we have a great webinar, and the lectures really were really amazing. And I think that it will help a lot of rhinologists that are just starting as I am. And sorry about my English, that is quite Spanglish.
That's great.
Lourdes, thank you very much. We really appreciated your hospitality when we visited you last time in Buenos Aires, and you've got a beautiful city, and we would look forward to visiting you sometime in the future.
Thank you very much, and please stay safe to all of you.
You too. Thank you, Lourdes. Thanks for organizing.
Bye-bye.
Bye.